done on the embryo biopsy. And then PGTM is only when there is a non-familial condition, monogenic condition. We are looking out for the mutation testing, which is present in the family, and we are aware of it. Next, please. So yeah, this is the same. So PGTA involves aneuploidy screening. Previously, people used to do 5 common aneuploidies and then do 7 or 9. And now we are doing it for all the chromosomes. So aneuploidies of any of the 23 pairs of chromosomes is done by PGTA. Structural rearrangements is when one parent has a known chromosomal aberration, which is a balanced translocation. Now, in a balanced translocation, there are breaks in 2 different chromosomes, and there is a switch of material from one to the other. The parent themselves, because they have the entire genetic material, they are normal. During cell division, abnormal or imbalanced material is passed on, and this testing can be done using PGT-SR. Next, please. PGTM is for monogenic conditions. So if we know there is something like a cardiomyopathy in the family, which is inherited in an autosomal dominant fashion, and any mutation that we need to look out for, we should have the index case worked up thoroughly well, because we need to know what we are looking out for. And it is a specific testing for one condition or one gene change or mutation, as we call it. Besides that, we also do PGT-HLA, wherein for the savior sibling, we do the HLA typing of the embryo, and we are just to see if it is compatible with the affected elder sibling. Next, please. So PGT fish testing, the way it is done is we get the biopsy, we transfer it directly to the slide. Of course, this is a low sensitivity method, and you need a very high precision in the lab. So a lot of people don't do this anymore. Next, please. And then we see the signals under the fluorescent microscope. So, when we've just got one cell or something, we do put multiple probes on that same cell to see these images of various chromosomes. Next, please. And for PGTM, when we are doing the DNA analysis, we collect the biopsy in what is known as a PCR tube. We add a cell lysate to it, and then the process of amplification, detection, sequencing is all carried out on that sample. And then we are able to see the single mutation that we are looking out for. Today, we can even do an NGS on the biopsy sample. So we get a whole lot of information from that small biopsy sample. Next, please. So this development of PGT is indeed one of the most exciting and important milestones in the history of assisted reproductive technology. And as I said in the beginning, genetic technologies are improving. We are getting more and more sensitive tests with a shorter turnaround time to be able to detect multiple targets. So because of that, it's going to help us treat our patients better. Next, please. Just want to end with one note that there has to be a constant dialogue or a back and forth between the IVF lab and the genetic center. We need to work together, and we need to understand the best benefit of the couples we are, dealing with, and what would be the best kind of test. And definitely, the clinics always want the report at the earliest. So to find the appropriate balance between getting the accurate reporting and in the earliest time, it is something we all strive for. Next, please. That's all from my end. I'm ready to take any questions if there are.
Yeah,
Excellent, Dr.
thank you.
Manjeet.
Thank you very much, Dr. Manjeet, for nicely explaining the genetic cause. Good afternoon, everyone. It's truly a pleasure to be here to chair this session on such a crucial topic of genetic cause of recurrent implantation failure. As reproductive medicine specialists, we know that implantation failure can be a frustrating and emotionally taxing experience for both patient as well as the clinicians. While we have made significant advancement in embryo selection, endometrial receptivity, and personalized stimulation protocol, the genetic aspects remains an area of ongoing research and clinical importance. And I remember a time when we always attribute most implantation failure to be a poor embryo quality or endometrial factor. But today we recognize that genetic and chromosomal abnormality, whether in the embryo, in the gametes, or even in the endometrium. Dr. Manjit has nicely highlighted the endometrial part also, the GDA factors. All these are responsible for RIF. And thank you very much for nicely explaining the different segments of the genetic causes, that is the embryo problems, gamete genetic factors, as well as the endometrial genetic factors. And now we know that there are a lot of tests available before implantation, PGT-SR for balanced translocation, PGT-M for family running some abnormality or genetic cause, then PGT-A and PGT-HLA. Manjit, I would like to know when would you like to go for PGT-HLA testing?
So, if the couple has a child who's affected with thalassemia or some of these life-threatening bleeding disorders, there is no cure and they require lifelong transfusions. So the parents usually plan another pregnancy for a bone marrow transplant
Mm-hmm.
from the younger sibling to the elder sibling. It
Okay.
could be any of these severe life-threatening bleeding disorders, and you need 100% HLA match for such cases. And you do get unrelated HLA typed HLA matched donors. Having said that, the sibling is definitely a highest percentage chance of being a match. So the
No,
parents plan.
yes.
Yeah.
Okay, I'm asking about embryo. Do we go for a PGT-HLA for of the embryo
Yeah.
in that case?
Yes.
Okay, so
Yeah, people do
basically, if the
it.
patient has some thrombophilia, histories of thrombophilia, in that cases, we can go for PGT-LA. PGT-A, M, and SR, I think nicely everyone knows that when to get it done. So thank you very much for
So I
nicely
will just add
explaining
on
in
here.
detail.
So I will
Yes.
add what Dr. Kokila was asking. So yes,
Yes.
genetic testing has moved beyond, finding a right match for the sickle cell and thalassemia affected patients, because going for bone marrow transplantation and finding donor has become a cumbersome thing. But if they go
Right.
for, IVF, have an embryo which is obviously disease free or in a carrier state, but HLA matched, but that not only gives them an option to have another child who is healthy, but also being a donor for their affected child. So yeah, so I think that is quite a lot which is moving on in genetics right now with ART techniques. Yeah.
Oh, yeah.
And
Thank you so much.
I
I think
I would really like to mention it is like remarkable that you all have included genetics aspects in the CME because as Madam has said that genetics is an integral part of every clinical whatever procedure
Mhm.
that we are doing. So be it a pregnancy loss, be it an implantation failure, now we know a lot of genetic causes for the
No,
same.
yes, it is
Yeah.
occupying a big segment in RIF. So we have to include that part.
Sure,
Thank you
sure.
very
And
much,
it's
Yeah.
Dr.
it's
Manjit.
my honor to be
Yeah.
invited here. I thank you once again,
Yeah.
Puneet ma'am, Dr. Kokila ma'am. Thank you so much.
And so thank you.
And
The
Dr.
slides were
Subui.
very good and they were very crisp. Actually, the slides were very good. So I must appreciate for that because at times in the afternoon, too much is written on the slide and we are not dosing. So the slides were very crisp. And of course, genetics has a long way to go and we are learning each day. Just one thing that I wanted to ask that before going for PGD, I guess that you always go for the parental genetic analysis before proceeding for that. Is that in the protocol?
So, if you're doing a PGTA for aneuploidy and you're having a general look at all the chromosomes to rule out any monosomies or trisomies, you can do it on just about anyone. But if you're looking out for something specific, when it is PGTM for a monogenic disorder, and you definitely need to
SR.
know what you're looking out for, even
Oh,
SR.
yes.
So if there
For
is
the
a
SR
balanced
also.
translocation in one of the parents, you want to rule that out in the embryo. So you have to know the breakpoints. You have to know on which chromosomes the breaks are, and you have to know the breakpoints. Accordingly, those are tested in the embryo biopsy. So the
Right.
pre-PGT workup is a big thing.
Yes, pre-PGT workup of parents as well as, and I have to go for micro array test to find out the location also.
True.
Fine.
I just have one question, Dr. Manjeet. So
Yes.
you mentioned about the endometrial GDDA and all, GDA test and all, which is low in recurrent implantation failure patients. Do we have mechanism to check it, test it right now? Is it available?
It is available in a few labs. In fact, some labs, they have put together a combination of several genes which play a role in the whole process, and they are selling it as RIF panel,
Okay.
So it is available definitely as a test. And if there is some lab that you are in regular touch with, you can ask them to even standardize this test for you. If you feel you or a whole bunch of your colleagues are going to send these referrals regularly, most of the labs can standardize any test, any assay on any genes. It is presently available. So,
Thank you. Thank you. So, Dr. Kokila, can we close this session then?
Yes, ma'am.
Thank you so much.
thank you, everybody.
Thank you very much for thank you very much for giving so highlighted and in-depth knowledge about the genetic factors. Let's now move to the ma'am. We are moving for first topic
Dr.
or second
Jayesh,
one.
Dr. Jayesh,
Dr. Jayesh's topic. Okay.
immunology.
So
Yeah.
Dr. Puneet,
Yes.
I just intervene. I'm able to open whenever it is possible and comfortable.
Thank you. Thank you. So we'll take Dr. Jayesh's talk and then Dr. Ritu we will take.
Right.
Yeah.
Thank
So,
Thank you so much.
please
If
keep the second chairperson's CV
Rahul,
here.
is it possible to minimize it because I've opened it with great difficulty with somebody's help? Yeah. If it is possible, then it can be minimized because otherwise I will face problem again.
Dr.
So-
Jayesh, are you there?
Or we can take
If he's
permission
not,
from Dr. Jayesh allowing me to speak first if it is possible.
Dr. Jayesh, are you there? Ma'am, Dr. Jayesh is probably, he has gone for the embryo transfer.
So
Okay.
can I take Dr.
I
Okay.
think we can finish with,
Your
we can finish the first part.
Yeah. Dr. Kokila, can you introduce the chairpersons for this talk, please? Rahul, can you play the CVs for the chairpersons?
Yes.
Rahul, are you okay playing this thing, chairperson CV?
Hope you can see my screen, ma'am.
No, Rahul, we can't see your screen.
Ritu, ma'am, you have to stop your screen share.
Oh no,
Okay.
you
Okay,
only,
Dr. Ritu is a little apprehensive, so I think let me
you
just
only
take out.
overlap because I had Dell and I started using Mac and I
Okay.
faced this problem.
Okay, so we will introduce the chairpersons. Dr. Kokila, are you okay to introduce the chairpersons?
Yeah, I could not see the CV.
So our chairpersons for the next talk are
Dr. Rajpriya and Dr. Mona Shroff.
Mona Shroff. Yeah. Are they here?
If
Dr.
there is a way
Rajapriya,
to minimize it, I will do it.
Dr. Kokila, you can just introduce Dr. Ritu Jain's this thing.
Can you put the CV of Dr. Ritu Jain, please?
Yeah.
Rahul?
I think he can't share because Dr.
No,
Ritu's screen.
You just
think he was
introduced me as an IFS member and I can start.
Yeah.
Dr.
Okay, Dr. Ritu,
Okay,
welcome. Dr.
Dr.
Ritu has
Ritu.
been the
Yeah,
space
Dr.
until
Ritu
now.
Jain. She's a IFS member, very senior IVF consultant, and I would say she was for a short period of time. She was mentor for me also and my center also. Thank you, Dr. Ritu Jain, and I would like to invite you here to speak on the topic of RIF. Please, ma'am, you can start.
Yeah, thank you everyone. And
She's a director of Vardhan Medical Center, and she has done lots of work even in laparoscopy as well as endoscopy. Welcome, ma'am. Here.
thank you, Dr. Kokila. And first of all, I must apologize my seniors and my friends for this technical glitch. This was new system, so I didn't know I will face problem. I hope I am audible. So the topic for today, recurrent implantation failure. We know it is a very, very distressing condition for the couple. And the only thing they ask is, doctor, what next? My sperm was good, my egg was good. So what happened that it happened this way? So then we always are in a fix. It is very easy to counsel a couple who is showing two line positive UPT, but the one which is not showing beta HCG positive, it is very distressing for us to counsel them. We all the reproductive specialist person try to get into the root cause of the problem and try to analyze what could have been the possible cause that the couple could not bear the fruit of fertility. So what is the definition of recurrent implantation failure? The old definition was that at least 4 good quality embryos in a minimum of 3 fresh or frozen cycle in a woman under 40 years of age. This was the old definition in 2014. Definitely, the couples above 40 also conceive. So, how do we define recurrent implantation failure in those patients? And 4 good quality embryos, whether they were cleavage stage or blastocyst stage, whether it was a single or dual embryo transfer, wasn't clear. So then next came another definition by Margolith et al., which included 2 egg donation cycles also. Another definition by Polanski in 2014, that 2 consecutive cycles, 4 good grade embryos or 2 blastocysts. But there was a need of proper definition, because as there is a shift in the reproductive age, there was a shift from multiple to single embryos, from cleavage to blastocyst stage, from untested to chromosomally tested embryo. So the implication of implantation failure and the definition definitely needed a change. So there came the new definition from ASHRAE Good Practice Guidelines in 2023, which described RIF as a scenario in which transfer of embryos considered to be viable has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant further consideration, investigations or intervention. So it describes it as a scenario, a clinical condition. Viable means that they have to be tested whether the euploid embryo can be called viable until unless it has invaded the until unless it has implanted in the endometrium and given us a positive pregnancy test. The positive pregnancy test means whether it includes the chemical pregnancy, biochemical pregnancy, biological pregnancy, or the take home baby rate, that is not defined. What is meant by sufficiently often? It is a vague thing, but specific patient, which means it is patient centric. It may be referring to patient's age or the condition for which the IVF has been done. And further considerations and intervention is again a broad term. Now let us go further. So there is a good variance in the definition, and they, according to Istanbul consensus, the ploidy status and kinetics should be known before we describe viability. Before we say that implantation failure has occurred, we should know what is the normal probability of implantation. In a normal human being, it is 25 to 40%, normal couple. But in aneuploid, all those embryos which we see are morphologically normal also have 67% chances of being aneuploid. And the best clinics have also 40 to 60% of success. We should know the probability of failed implantation with the good cleavage stage when we counsel these patients. When 3 cleavage stage embryos are transferred, chances of failed implantation is 34%. When blastocyst is transferred, it is 2 blastocysts, it is 36%. So if, in spite of everything being normal, that is the normal probability with IVF ICSI cycle. So in recurrent implantation failure or any IVF failure, we need to see where is the problem. Is it uterus or is it embryo or the crosstalk, which could not happen successfully due to some problem or some molecular changes or vascular remodeling changes, or decidual was not properly formed when the process of apposition, adhesion, and invasion had happened. Was it a early implantation failure or late implantation failure? The causes can be largely due to embryonic, that is genetic abnormality, female or male, female age, quality and integrity of sperm, or decreased endometrial receptivity, whether it was a structural or hormonal factor, the crosstalk or the immunology coming in, embryo transfer technique or QA/QC of the lab. Taking first the embryonic or genetic abnormalities, age of female being the more important. When couple comes, a complete medical history and physical examination is mandatory. Assessment of ovulatory function, AMH, ovarian reserve testing, ultrasound. Same way, the medical history of the male and physical examination and semen analysis. Now, there is something IVF predict calculator which tells us when to intervene. If the embryos transferred were of unknown aneuploidy before the 35 years of age, after 3 embryo transfer, intervention need to be done. And same way, as the age increases, aneuploidy increases. In more than 40 years of age, the intervention is needed after 6 embryo transfer. But when it is euploid embryo transfer, say any age, 35 to 40, even after 2 failed embryo transfer, intervention is needed. So the cutoff is taken as 60%. RIF is suspected or need to be further investigated and worked up when it has failed to meet the 60% implantation chart. So age, we know with advanced age, the chromosome and genetic abnormalities increases exponentially as we see like 40 to 47, it is almost 37% chances of having aneuploid embryos, where in young age, it is less. When aneuploidies are happening in young women, it is particularly due to chromosomal breakage, especially in the centromere region. Whenever a young female is expecting high order RIF, these are the probable reason. Well, Poseidon group definitely very clearly strategizes the aneuploidy and euploidy status between different age groups and helps us counseling the patient that there is a difference between age in the group 1 and group 4. In group 4, the aneuploidy increases remarkably, and more number of oocytes are needed to get a euploid blastocyst. As we say, more the merrier. So, well, can we reverse the age? Can anyone from group 4 be moved to group 1 with any signs possible? No. Although there are different medical options available, like putting the testosterone gel or giving DHEA, which have not been approved by major societies like ESHRE and ASRM in giving growth hormone, improving the energy level of the mitochondria by giving coenzyme Q, or changing the personalized stimulation protocol by increasing the dosages, or moving entirely to antagonist cycle, or adding recombinant LH to recombinant FSH for stimulation, or using GnRH short agonist protocol, luteal phase priming with estrogen. And last come the oocyte donation when nothing has worked in 3 to 6 cycles. Now, we know that sperm also contributes to aneuploidy in almost 50% of the cases whenever there is a failed fertilization, especially in cases of severe rods, the karyotypic abnormalities needs to be ruled out. And with changing lifestyle, we know that lifestyle oxidants are increasing to great extent, and also with increased use of preservative and endocrine disruptors and habits, lifestyle, smoking and alcohol, teratozoospermia is on rise. So another measure is to improve sperm parameters. If there is some infection, it has to be treated completely and adequately by 14 days of course of ofloxacin or doxycycline or according to the culture. Well, karyotyping has to be offered in severe oats, and antioxidants do have some role. Or better sperm selection techniques have to be used, like Pixie, and in severe male factor, ICSI is the answer. So, ASHRAE has given certain recommendation for investigations. First and foremost factor is review the lifestyle factors, because there is a major change in lifestyle of the couple and advancement in the reproductive age. So lifestyle factors become very important. Then comes reassessment of the endometrial thickness. A review of estradiol treatment is recommended if endometrium is noted to be thin, and whenever suspecting Escherman, hysteroscopy is needed to rule out for this. It is important to take a complete assessment of antiphospholipid antibody syndrome, because it is an additional factor for thrombophilia and should be considered in women even without such risk factor. The testing should be done. Few investigations they have recommended as to be considered: karyotyping in absence of any chromosomal abnormality, and if it is detected, then genetic testing, and of course referral to genetic specialist is required. 3D ultrasound is very important to view the uterine cavity in detail. It gives us much more information regarding the subtle problems. Hysteroscopy, whenever any uterine anomaly is suspected, say polyp, myoma, it needs to be done even in cases of previous one IVF failure. Endometrial functional testing can be ordered. Chronic endometritis should be considered, and if it is diagnosed, it has to be treated adequately with antibiotics. Assessment of thyroid function is important, and assessment of late follicular and mid luteal progesterone level is recommended. Karyotyping, I already said. And then thyroid function, the value less than 0.4 milliunits for subclinical hyperthyroidism and more than 4 milliunits for subclinical hypothyroidism. And whenever antibodies are present, needs to be treated, because it definitely improves the progesterone function in the luteal phase. Now, adequate progesterone level is very important. In fresh embryo transfer, whenever serum progesterone is more than 1.5 nanogram per deciliter, it is advisable not to transfer in the same cycle, because endometrial embryo asynchrony will not allow implantation to happen. However, it is not a routine practice to measure serum progesterone. Some centers do measure, some do not measure. So Cochrane meta-analysis reported a higher live birth rate and ongoing pregnancy rate with progesterone compared to no treatment for luteal phase support, and OR being 0.77. So adequate progesterone level is needed for embryo to implant. ASHRAE does not recommend any testing for vitamin D or uterine or vaginal microbiome profiling. Peripheral or uterine NK cell testing, lymphocyte assessment of the uterine cavity, cytokine level assessment, HLA, and sperm DNA fragmentation test is also not recommended as per new guidelines. Although most of us are deficient in vitamin D, and we try to optimize, because variety of studies have different things to say. Same for microbiota. Uterine dysbiosis definitely impairs reproductive outcomes. A large meta-analysis suggested that good microbiota is imperative for implantation, whereas another small case control study showed that it is of vaginal lactobacillus, not the endometrial lactobacillus, which is important. Then to improve the oocyte and sperm parameters, as lifestyle is very important, planning at right age, which cannot be reversed, certain things which stated can be done. Then PGTA to know the euploidy status, assisted hatching and blastocyst culture, So ASRM has suggested that PGTA should be used in advanced maternal age to select euploid blastocyst. And there's another study by Fertile Sterile said that PGTA and ERA in RIF couple do not seem to offer beneficial reproductive outcome, and couple should be counseled appropriately while offering treatment options. So different views are there. Another group said that PGTA it did not improve the pregnancy rate. Assisted hatching, though, increases the risk of monozygotic twinning. Sometimes was used and still being used certain labs for women over 38 years of age, advanced age or thick zona or repeated implantation failure with variable results. So, and what is actually needed is numerical analysis of all the 24 chromosomes, and that is comprehensive chromosome screening, which can be of help in patients with RIF. Time-lapse monitoring improves the implantation rate by helping us select, knowing the morphokinetics and helping us select better embryo. It improved the pregnancy rate. Then blastocyst culture definitely helps selecting more euploid embryos when PGTA is not available. So most of the clinics have already moved to fresh blastocyst transfer or frozen, as the case may be. Mitochondrial nutrients, according to some study, improves the outcome. And this was a prospective study, double blind control study, which showed that CoQ definitely improved pregnancy rate in previous RIF cycle. Now, coming to the host factors like endometrial, be it anatomical or functional, needs to be improved in cases of RIF. Checking for endometritis and treating adequately for mycoplasma, chlamydia, gardnerella. Then thin endometrium treated to be needs treatment with estrogen therapy, GCSF or cabergoline. Another approaches for receptivity have been endometrial scratching, intralipid, IVIG stimulation protocol change, or the blood flow with low dose aspirin or L-arginine. Let us see what are the recommendations regarding these. So after one IVF failure, it is worthwhile to do a hysteroscopy to look for chronic endometritis, as this has also been suggested an investigation to be considered. Local or diffuse micropolyps, stromal edema, hyperemia, or pale endometrium or strawberry look aspect, hemorrhagic spots, they all are suggestive of chronic endometritis and need a complete treatment. It is the streptococci and Gardnerella which are more prevalent. Although lactobacillus species are only 10% of the microbiota, but it produces hydrogen peroxide and lactic acid and prevents the growth of another microbes, and it definitely makes the immunosuppression which is requested for an embryo transfer better, and it regulates the cytokines, leukocyte infiltration, autophagy, desitorization, and uterine contractility, and definitely the vascular changes. So endometritis is an important aspect to be treated, and there has been shown improved outcome in patients who are adequately treated. Maternal anatomical factor, be it fibroid, adhesion, polyp, Asherman, and they need to be treated. And the study has shown that those patients who had hysteroscopy following the IVF failure had the better outcome than those who did not have. So this here I would like to state a case of 9 IVF failure where everything was done, and I did an hysteroscopy for this patient, and there was a very subtle subseptate uterus. Although there is a lot of controversy regarding to treat this or not treat, we did a resection, septal resection, so that both the cornu could be seen in one plane. So lucky for that patient, she could succeed in that cycle. And as such, the literature also says that subtle factors need to be treated when nothing is working out and there is subtle anomaly. So the resection also helps in improving the implant. Resection of septum helps in improving the implantation. Although there is not sufficient evidence if we go for recommendations. 3D ultrasound has become a part of investigation now. What about myoma? Everyone knows that FIGO 0, 1, and 2 needs to be resected. Sometimes the dilemma is between 2, 3, and 4. Intramural myoma, if it is more than 4 centimeter, needs consideration in patients of recurrent IVF failure because it can significantly impact the implantation by disrupting the junctional zone flow or leading to uterine dysperistalsis. It has high aromatase factor, E2 receptor, and progesterone receptors are disturbed, and there is altered hyperplasia and abnormal tissue growth. In Indian population, of course, we have to look for COX and by the doing the complete genital tuberculosis panel test, and if it is there, we need to treat these patients. Dr. J.B. Sharma has shown this in a paper that Gene Expert had a sensitivity of 33 to 50% and 100% specificity, and patients treated had a higher conception rate. What about PRP? It is autologous, the best point is, and it is a thick concentrate of granules containing growth factors, which stimulate a implantation cascade and healing process. Same for peripheral blood mononuclear cells. It also helps in implantation. PRP, we know that it helps in patients of adenomyosis, thin endometrial lining, chronic endometritis, and Escherman. It really helps as it promotes neo angiogenesis, especially in scarred endometrium. Hydrosalpingo fluid needs hydrosalpinges need to be treated adequately. We know they are embryotoxic, can cause altered uterine receptivity. The direction of the uterine peristalsis is changed, abnormal cytokines, flush out effect. By clipping or by removing is again a controversy. Some people prefer clipping as it maintains the blood supply. Anyway, the adequate drainage has to be assured. And if salpingectomy is to be done, it is to be done very close to tube so that the blood supply is not altered. It has a positive effect and improves the ongoing pregnancy rate. Same for the fibroids. The literature shows that there is improved in the pregnancy rate. Adenomyosis is a dilemma because in adenomyosis, the whole uterine contractile, there is a dysperistalsis and abnormal profile. And if it is diffuse, there is hardly any surgical treatment which can be done. The medical treatment to improve the implantation includes the transfer in the freeze all and transfer later. And letrozole protocol is better for preparing the endometrium. Then thin endometrium, it is important to check the prolactin levels also. And the blood flow improvisation needs to improve the blood flow, the estrogen, aspirin, vaginal sildenafil, pentoxifylline, tocopherol, so many therapies are there, and everyone uses them despite there are controversial recommendations. By systemic review and meta-analysis shows that low-dose aspirin is of no benefit in IVF program. Same way, local endometrial injury, that is endometrial scratch. According to some studies, it has a positive effect, increasing the pregnancy rate, almost doubling the pregnancy rate. As it increases osteopontin, AVB3 integrins, and biologically active factors which are involved between embryo and endometrium. This study also shows that there is a positive effect. Endometrial injury done by PIPL or by hysteroscopy has a positive effect in improving the implantation. Steroids have no benefit as shown by 13 RCTs. GCSF is being used recently by all the reproductive specialists a lot. It increases the endometrial thickness by 4.1 mm in comparison to estradiol and sildenafil, and it increases the clinical pregnancy rate also, OR being 2.03. It is given in the proliferative phase. Same way, intralipid therapy also enhances implantation and pregnancy. IVIG also improves TH1 TH2 ratio in cases of previous IVF failure, and in those with HLA similarity, it is recommended, but the scientific data says that they are of no use. So the crosstalk has immunomodulation. in cases where there is autoantibodies, thrombophilia, TPO antibodies, or abnormal NK cell, the immunological treatment recommended and used is heparin because it improves desitalization with activation of growth factors, cytokine expression, which are favorable for the pregnancy, and it triggers so many immune modulating factors, and it helps in implantation. The another review in human reproduction also showed that it is of help in immunological cases which have immunological background. So sorry. This study showed that in patients with RIF with or without thrombophilia, the miscarriage rate when heparin was used definitely decreased and implantation rate increased. Error testing, the treatment cycle should be replica of the test cycle. Many studies have shown that there is a positive effect according to ERA, increased pregnancy rate by 62.8%. Stem cell therapy in patients where there is Escherman, it helps by after hysteroscopy and histiolysis, it helps in regenerate the endometrium with autologous stem cell after curettage. There is a role of uterine relaxant, atosiben, in the study by Moralgu et al. In used in 113 patients and gave the live birth, which was almost similar to the control group. HCG, it is a glycoprotein which helps in endometrial adhesion, angiogenesis, trophoblast invasion, implantation, improving the vascular endometrial growth factors and interleukin levels. And it is being used in frozen ET cycles because there is no production of HCG, and that is how it started improving the result. GnRH agonist in the treatment cycle, it is given day 6 or day 7 of ovum pickup. It increases the LH production and supports the corpus luteum function and improves the binding of the embryo. So embryo transfer technique is very important. However good the host factor may be, however good the guest factor, that is our embryo may be, but if it is not handled properly in the or handled in atraumatic way, not allowed to place like embryo, if it is not placed at the right point and if not placed under ultrasound guidance, it can put all the efforts in vain. So the angle should be corrected and specialized soft catheter under ultrasound guidance. This was a good article in Fertility Sterility, revisiting the implantation failure through freeze-all policy by Shapiro et al. And they showed that clinical pregnancy rate almost doubled when the freeze-all cycle was used. But there are certain recommendations and certain interventions for these patients as recommended by this group, ESHRE group. It said that review estradiol treatment if lining is thin. So definitely when we are doing frozen embryo transfer, estradiol treatment plan has to be reviewed. Patient care and counseling is important because stress is such an important factor. Stress itself can lead to implantation failure in 20 to 30%, and it is imperative and very important to optimize lifestyle factors. Well, PGTA, blastocyst culture, and antibiotics if chronic endometritis can be considered. In fact, they are always considered. And there is a strong recommendation not to use endometrial scratch or immunomodulation like GCSF, IVIG, PBMC, PRP, HCG injection, low molecular weight heparin, agonist, aromatase inhibitor, and assisted hatching. I read the whole this recommendations, ESHRE recommendation, and I was wondering that there is a strong emphasis on testing the APLA and the antibody, but there is no recommendation group for low molecular weight heparin. So I don't know how the things will. But well, there is some answer by this optimum trial in 116 IV recurrent implantation failure, where they identified the cause and they treated the cause appropriately and adequately. And they found in this optimum group that OPR was high when the cause was treated. I think that is the way forward for all of us. And for recurrent implantation failure, I can only say that लहरों से डर के नौका पार नहीं होती और कोशिश करने वालों की हार नहीं होती. So I think we as reproductive specialists, we try to make our best and try again and again for our patients. And thank you everyone for patient hearing, and I'm open to any questions.
Dr. Mona, are you there?
Yeah,
Can you
yeah,
please
yeah.
conclude the session?
So, thank you, Dr. Ritu. That was indeed a very well structured presentation, because, as we all know, RIF is like huge and vast, and to concise and present in such a beautiful way. So, thank you so much. Uh, I think we have understood the multifactorial nature of RIF. You have even explained the importance of, a thorough evaluation about the endometrial receptivity, the immunological factor, and most importantly, the embryo quality. And I think, as per me, it is 80% is the embryo. So embryo is the boss. And we even discussed the emerging interventions and the treatments available, which is recommended as per evidence-based strategies. So I think this presentation is going to spark a lot of discussions and a lot of questions from the delegates. So thank you once again. And I would also want to ask a couple of questions, but we'll open it for the discussion, and later I'll ask.
No, you can, Mona, you can finish your questions.
Yeah. So I wanted to know your experience about natural cycle embryo transfer in RIF. That was my first question. And second question was about embryo glue. If, like, what do you think?
I haven't found embryo glue to be of any use. Even my embryologist does not recommend, and the studies also
Right.
do not favor it much. And in
Right.
natural cycle embryo transfer, we have to do a lot of estrogen, progesterone monitoring, and daily calling the patient. I have been using modified
Natural.
natural embryo, or sometimes whenever needed, mostly HRT, otherwise modified natural, and sometimes the stimulated cycle also, giving gonadotrophins also whenever, it is a very resistant thin endometrium. In fact, we are using that also.
Okay. Thank you.
Thank you. Moving
Any
on.
question from the audience?
I think we can take maybe after Dr. Jay's talk together. Is that okay?
Sure.
Yeah.
Sure.
Okay. So moving on, I think, thank you, Dr. Ritu. Moving on to our next topic, which is on immunology. It's my pleasure to welcome Dr. Jay Shameen. He's a clinical director at Nova Wings and national advisor of IFS, and has got a lot of publications, and has ever won the Award of Excellence in IVF Treatment by Union Health Minister of India in 2016. Over to you, Dr. Jesh, for your talk on
I would like to
understanding.
invite both the chairpersons, Dr. Puneet, one of them, and Dr. Praful Doshi sir. Dr. Puneet ma'am is a gynecologist and fertility specialist, founder and director of the Gurgaon, executive member of IFS, founder member of Fertility Preservation Society, and she's a medical advisor in a cancer survivor project, advisor in a many other centers, executive members and fertility advisor at TYCAN India. She has been awarded with the Bharat Gaurav Award for excellence in the field of reproductive medicines, and also she has a peer reviewer for many of the journals, and she has 30 publications in a high impact journals. And her main area of interest are primary, secondary, tertiary care provider in all aspects of infertility, with special interest in RIF, low prognosis patients, fertility preservation. Welcome, Dr. Puneet ma'am. And I would like to invite Dr. Praful Doshi sir as a chairperson. He is a director of Me and Mummy Hospital, chief fertility specialist in the Blossom Hospital. He is practicing since last 40 years. He has been ex-professor for Surat Medical College as well as Jamnagar Medical College for 18 years. He has taken vast training in laparoscopy from Germany, advanced training in IVF from USA and Australia, and he has been an examiner for many years for MBBS as well as MD exams. And his special interest in music and reading. Welcome, Dr. Praful Doshi sir. Dr. Jayesh, please, you can start your
I'm ready. Thank you so much
Yes.
for giving place here, Dr. Puneet. And I think so. Wonderful talks going on specifically on the recurrent implantation failure. And I think so we cover everything which is called as a baseline of the recurrent implantation failure. नहीं हो रहा है वो, क्यों नहीं हो रहा? इसको click करते हैं? So today's my topic is understanding the immunological aspect. I'm not going to cover more something about the therapy, then it will take around 1.5 or 2 hours because it's a very huge lengthy topic which is called immunology. And let me tell you, this is the ASHRAE guidelines because everybody will start something about the ASHRAE guidelines, and there is no doubt about that. Guideline is sharing something that investigating immunology is a waste of money. And specifically, I think so, as far as concerned the nature killer cell, then going beyond something HLA and key, a lot of things are there. And get guideline is saying that no, you can't, you cannot investigate the beyond the PGT. So here, what I want to just conclude that whatever the guidelines are saying, what is guideline? Conclusion, ASHRAE guidelines are an invaluable starting point, but they should be adapted, but not adopted blindly. Fertility care in India requires a balanced approach, a global based practice combined with local realities. By prioritizing clinical judgment and investigating a local research, we can provide a better care and achieve. And my conclusion is very that better outcomes for our patients. Let's focus on creating India specific solutions while building on the global expertise that ASHRAE provides. So this is my answer toward the any guidelines. And let me tell you that already Dr. Ritu Jain and Dr. Mahima already said something. They prepared a very good genetically normal embryo and now they fail. So I'm going to discuss about the genetically tested embryo which is formed and why there is an implantation failure. Because before I explain anything implantation failure, let's understand the physiology. And you can see something about that. This is the pyramid of implantations or pyramid of live birth rate or something creating a baby. We can say when embryo naturally implant also, there are some 30% pregnancy loss. So there will be a preclinical loss, 60% preclinical loss will be there. Where there are 30% preclinical loss is because of genetic loss. The genetic loss, that means there is an aneuploidy will be there. The rest of the 30%, which is considered as maybe a genetic or 40% maybe a genetic or maybe a something which is rejection of the embryo. So at that we don't know what is the reason behind the pregnancy loss. And that is what we have to just find out. But here we are very confused that what is come first? Should we go for the immunology first? Should we go for the PGT first? Or should we go for the receptivity first? And that's why we don't know whether the egg is first or chicken is the first. And again, I will say something about should we reassess the embryo first or somebody will say that I reassess the endometrium first. So this is still we need much more randomized control trial and much more research. But what I understand that if you don't do genetic testing, then you require minimum 4 embryo when your age is less than 35. So every failure is there. Every implantation, when you implanting a genetically non-tested embryo, there will be a failure of around 75% when it is single embryo transfer will be there. So you require around 4 embryo transfer to complete around 90 to 95% clinical pregnancy rates. But as in increasing, you can see something about number of embryos are highly required. And basically when there is a more than 37 years of the age, you require 7 embryo. Could you believe that when you transfer 7 embryo, it is so frustrating for patients? And that is why the new study, which I believe that what is the role of the the aneuploidy, especially in the age-induced genetic aneuploidy. And this is a beautiful retrospective data of 15,169 patients, where we say that age increasing. Look at that. Whenever the age is increasing more than 38 years, the aneuploidy rate is highly increasing, around more than 50% is there. So we need to always implement a genetic screening. But when we go to the definition of recurrent implantation failure, which was discussed by the Ritu Jain, that we are now on that, whatever the things we are performing, whenever we reach the threshold of more than 60%, even if we are not getting the pregnancy. So up to 60%, less than 60% of the treatment, then we need to repeat the same treatment again and again. But when we are proceeding, we are applying the technique where we should go to beyond the threshold of the 60%. And if we are not getting pregnancy, then we should go by the certain add-on will be required. And this is how we can have an add-on, how we will decide. This is the IVF predict according to age with the genetically transfer and non-genetically transfer. In genetically transfer, there is no about that with intervention is required after the single embryo transfer of the 2 embryo transfers. And when there is the intervention a non-genetically transfer, it may be a 3 or 4 genetically. So practically I think so the 3 or 4 embryo transfers, then we have to intervene. And as we know that when we intervene, what exactly, and this is a beautiful study that what we say that when we transfer retrospectively 4,000 patients, single genetically PGT normal embryo transfers, 4,429 embryo transfers, but single embryo transfers. And look at that, what we are getting that a first embryo transfers, we are having a clinical pregnancy rate is 69.9%. And then later on the remaining population, when we transfer the another second one embryo transfer around 900, 450, 700 patients, then we can have again 457 patients are clinically pregnancy rate, that means 59.8% CPR rate, live birth rate is 54.4%, and the dropout ratio then is excluded, and then again we transfer around 200 patients, so 150 patients there where the other patient 79 will conceive, so it will be considered as 60.3%, and the live birth rate is around 54.1. What it includes? It includes that our clinical pregnancy rates is, if you are adding the dropout rates, that is around live birth rate is around 92%, and the clinical pregnancy rate is around 95% is there. Then again, there is one more study which was published that if you transfer single genetically euploid embryo transfers, right, one by 5 times, then again the clinical pregnancy rate will reach to 99%. And what it says something around only the endometrium is responsible for only 1%, or the endometrium is responsible for the 5% will be there. And this is my own study which was previously published for the ERA. And I used to say that this is the 219 patients of the ERA is recruited. And then I show something around that more than 48 hours. So P plus 3 and more than P plus 6. So more than 48 hours disturbance, which was window period of displacement, which is seen only in the 6%. So rest of the all the displacement is only around the P plus 4 or P plus 6. That means the 48 hour disturbance is there, but there is no window of displacement more than 48 hours. And again, I want to say if I apply only ERA and transfer the embryo transfer, then the pregnancy rates will be around 34% when I combine with PGT. So you can understand that what is the importance of the PGT. So allowing ERA first and hierarchy are doing a PGT the next, I think so it is not good. It is always better to test the embryo rather than to go for the window period. And followed by the systemic review and meta-analysis, which again says that there is inconclusive. That means that there is no role of ERA. And I still say something about that. Only 1 to 3% where I would be like to see something about what is the window period compared to my previous studies and previous experience will be there. So no doubt that 48 hours, I will say ERA is always open. That means window period is open. Then what exactly going on? Why there is no? Again, we are thinking about the thin endometrium. Again, the beautiful study that genetically euploid embryo transfer in the thin endometrium in the different variety of the endometrium, maybe a less than 7 mm, less than 6 to 7 mm, 5 to 6 mm. Look at the different protocol also. They say that the pregnancy rate is same. Now, the conclusion is that we did not, what exactly we want to see something, that what is the exact question we want to ask. What we did not identify a threshold of ET at their precluded live birth rate under the which live birth is especially there. Common practice of cancelling embryo transfers when ET is like, so this is what about the thin endometrium. But when we talk about the euploid embryo after excluding the chronic endometritis, the 4 question and where I want to put my all the questions to find out the crosstalk. Question number 1, that what we will do when consecutive 4 SET failed in younger age when genetically tested, not tested embryo. When we transfer PGT normal embryo, if there is a normal implantation is around 50 to 60% or 60 to 70% of single embryo transfer, then what about that other 30 to 40%? Why? What is the reason behind that? Why they don't implant? And when we transfer the euploid embryo, then why euploid embryo is having a miscarriage? What is the reason behind the miscarriage of the euploid embryo? And the last thing, that when you choose the egg donation, if you transfer the egg donation, what is the after 3 consecutive egg donation embryo transfer, maybe a 5 egg donation embryo transfers, or maybe a 4, or maybe a PGT tested 3 normal donor egg embryo transfer. What is the reason behind the implantation failure and miscarriage? This is what I want to say, that this is the reason is only immunological. And then we need to open this immunology. Then we know that there are naturally the immunity is around innate immunity and adaptive immunity. Innate immunity, that means the foreign body. Let's understand the foreign body will go inside and our nature killer cell will kill. So saying that when anything which is going inside the body, the nature killer cell will activate and they will kill the embryo. And another part is that they form the adaptive immunity if they come again and again, or might the human will form the antibody by the B cell. So B cell is a humoral immunity or adaptive immunity. So same thing I want to explain, that when embryo will go, let me understand, when we are doing intercourse or we are something entering some foreign material, there will be some response to our blood and they will form the peripheral nature killer cells. So we need to understand now what's exactly going on. So is it peripheral nature killer cell or uterine nature killer cell? That is what in the initial part of the infertility, that measuring that will give you any idea, any idea that, okay, it is higher, so your implantation rate, or we can reduce that nature killer cell activity, it will increase your implantation or not. This is how the naturally, when we have an implantation, the nature killer cells will increase during the secretory phase and during implantation, and they will reduce when there is a delivery or there is a termination of the pregnancy, at term size will be there. So this is the variability of the nature killer cells, and that's why the meta-analysis we say that measuring of the nature killer cell is not have no value. So every physiologically there will be increase during the pregnancy, there is no value, it will not give any idea. And that is why all the meta-analysis at the end of the day, they say that there is no point to measure the no significance of detailed analysis of the peripheral as well as the uterine nature killer cell is there. So what is important? Number will not explain the action of nature killer cell. It's all about that action on the nature killer cell, whether it is activated and silencing. So two part is important, that activations and silencing. So we need to go, this is a good publication of Juan Velasco, and they said now the time to move toward to find out that how these nature killer cells will be going to activate and deactivate. That means activations and silencing. What is the mechanism behind that nature killer cell? And this is called crosstalk. So I can say something about, we need to open the crosstalk between the embryo and maternal immune system. And for that, we need to understand what is immunotolerance. Let me explain very thoroughly that immunotolerance, that when the husband is doing, when there is an intercourse, history of intercourse is that sperm will go inside the vagina and they will go inside the endometrium. And when they go inside the endometrium, they will expose to lymphatic system. And when they goes to lymphatic system, the lymph node, they will act antigen presenting cell will goes to the T cell. And this T cell will form initially the response, just like a virus response. So the peripheral blood nature killer cells will increase. But when there is again and again exposure of the same paternal antigen will be there. There will be the formation of from the adaptive immunity. And in that condition, I think so this peripheral blood nature killer cell will go into the thymus, and then they will convert from cytotoxic to cytolytic. And that is called Treg cell, the T regulator cell. And that's why some of the Treg cells will be present in the peripheral blood, and some of the Treg cell will be always in the residua of the endometrium. So this is how the Treg cell will form. This Treg cell will always having a response will be there. What we will say something about, that whenever the Treg cell is higher, it is called protective. So if you want to measure that what is the reason if Treg cell is low, the one of the most important investigation that I can feel in the blood, that if the Treg cell is low, then we need to increase the Treg cell anyhow to protect the pregnancy. So that is the another one inference that I can say. In a good pregnancy, without healthy pregnancy, there is a high amount of the Treg cell, because there is immunomodulation was done by the natural intercourse very well, and Treg cells is present, so pregnancy is protected. So now I can say I will usually explain that intercourse is a vaccine. Yes, it is a vaccine. So they are stimulating our innate immunity, and then it will convert into the humoral immunity, adaptive immunity, and they will form the paternal antibody and Treg cell. So these are the two things is more important. If there is no paternal antibody, there is no protections. And if there is a no Treg cells or the low Treg cell, there is less protections, and it will kill your embryo will be there. So certainly the paternal antibody and Treg cell measurement is so important when we talk about the rejection of the embryo, recurrent pregnancy loss, or repeated implantation failure will be there. So now we have to ask the question. So it means it is not kidney transplantation and embryo transplantation, both are different. Kidney transplantations or 100% antigens are from outside, where we can see in the embryo transplantations, it is a 50% from outside and 50% will be from own. And again, I want to say that the 50% is already recognized by the immune system, already recognized, and they have an antibody as well as the Treg cell inside will be there. So we have to now investigate. Again, I'm saying that beyond natural killer cell, that means the crosstalk can be open. What exactly? Identification of the cell is called HLA system. Identification of the cell is called as the HLA system. And HLA in the embryo, 50% come from the father and 50% come from the mother. Now, this is the embryo. And on the surface of the extravillous trophoblast, there is every cell, extravillous trophoblast, every cell is having a HLA receptor. On the surface, the receptor, it is called C receptor. And this C receptor will talk with the maternal immune system, with the messenger, it is called, again, the one protein is called KIR. And then they will give the message. Look at this, the last right one slide, the image, it says that whenever you implant the embryo, on the surface, HLA, that means on the surface C receptor, that means the C receptor will interact with the KIR, and this complex will give the message to the maternal immune system to decidual nature killer cell, activate. If they activate them, then they will kill the decidual nature killer cells and they will go inside the endometrium. If they are silencing, in between there is a silencing, then there will be something more vascular regenerations where it is required during the silencing phase, and the embryo will develop, and it is called the harmony of all the endometrium and the decidua will be there. If all this will be taken care as a cruise control, automatic cruise control, then embryo will definitely go insidely, properly, naturally, and that it will go up to 9-month pregnancy will be there. So I can say that after that, when embryo will go inside, so there is an embryo endometrial interface. There is a crosstalk at the level of the surface, and there is a crosstalk at the level in the blood. There are two systems. Blood is having a other identification, and system, when you enter on the surface of the body tissue, then there is a other identification system. So this is called HLA1 and HLA2. We are talking about the HLA1, 2. Both things are together basically responsible for the penetration of the embryo and formation of the decidualizations and implantations and placentations. If good placentation will be there, with the help of all the cytokines, the pregnancy will be at the end of the day a fruitful pregnancy, or output is always positive will be there. So now what we can find out, how can we open this crosstalk? So first thing is we have to find out the HLA-C on the surface. On the surface, that means what? We have to find out the signature. We always name the baby when he born, but before he born, there will be a signature of the HLA-C identification. It is called signature. So we have to find out the biological signature of that embryo. Second thing is more important is sharing. That means if mother and father is sharing more all HLA, then they both are maybe a brother and sister compared to the husband and wife. So sharing is more important. If HLA compatibility is sharing, more sharing will be there. Then there will be a no paternal antibody, because they will immunology consider their own body and they will not form the paternal antibody, and immunotolerance will be not there. And later on, when they go inside the blood, they need to see something autoantibodies. And this is called autoantibodies, those who are going to act on the paternal antigen or maybe maternal their own, because they are autoantibodies. So they are acting on the paternal antigen, they are acting on the maternal, they feel like a maternal tissue or the maternal antigen. And this is why Because of that, there will be a multiple miscarriages and multiple pregnancy loss or multiple implantation failure is there. Now, the most important and treatable that you can do when you do the HLA test, as we are doing HLA test, where you can easily find out the sharing. They will show that how many HLA alleles are shared. And the beautiful, so in the past, it is only because of consanguineous marriage. Now you know that it can add, it is added by a close community marriage, and today we can have a global world nowadays. It can be added by selecting a partner by website. So this is all about of these things which is adding more and more sharing maybe, but what exactly, how much sharing is detrimental? And this is a beautiful paper, and that is what we are implementing in our day-to-day practice. I can say that more than two sharing of the HLA, it is considered that this is detrimental. That means paternal antibody will not form, immunotolerance is defective, and we are always using this HLA sharing, and we find out that so many patients, more than 5, more than 6 sharing. And if we go for the paternal antibody test, it's a different test. We are not just doing that sharing in the blood. We will have a different sensitive paternal antibody test, and we found out that paternal antibody is less, Treg cell is also less, so everything is less. And more sharing in this condition, I think so, if more than 35% sharing or more than 45% sharing is there, most important, donor lymphocyte. And this is what I submitted, one more paper of donor lymphocyte. I believe in donor lymphocyte. I don't believe in husband lymphocyte therapy. Husband lymphocyte therapy is only indicative of less than 1% when there is an unexplained RPL. No cause is find out, then and then I can do. And donor LIT is only indicated only 1 to 2%. You will not have a more than 2 or 3% patient, those who are having a sharing in the TG group of unexplained RIF or unexplained RPL. So this is my paper which we submitted in the ASHRAE. I think so. They if they accept, then it's okay. But this is what we are showing, that when there is a 4 IVF failure and 5 IVF failure and multiple miscarriages, it is having a very good role and giving around, in this group of the patient, that they will give after donor LIT around 65% pregnancy rate implantation. Though it is a very small study, small number of the patient, but we will come out. But we practically, by our observation, we feel that this is a typical thing that we need to find out before transfer, that sharing is there or not. This is one more study which our group we published in Human Reproduction Journal in 2023, that low dose LIT is more beneficial, especially when the sharing will be there. So now let me go after the sharing, what exactly we can know, the signature of the embryo. So let's open the signature of the embryo. How can we do? This is the test. So we are always sending the husband and wife blood, and then we will receive the HLA report, and then we will receive the signature of the husband and wife. We didn't receive the HLA of the embryo. First, before the making embryo, let's go the signature of the husband and wife. And specifically, we only go for the C, because C is the first receptor which in turn to interact with the the maternal immunology system. So first we have to go by the C system. And when we say something HLA-C on the extravillous trophoblast, they interact with the KIR and additional natural killer cell, and they will form the activations and silencing will be there. So look at this, is a very beautiful diagram, that if husband and wife is having a husband and wife. So what are the different HLA of the embryo? It may be a C1, C2. C1 is activating, C2 is silencing. So there are different combination of the HLA will be there. So let's say something, if father and mother both are having a report of C1, C2, then that's good, because they are having a silencing and activations are both together will be there. But the most important part is when they are having a more C2. So here, if you transfer 2 embryo, then more paternal C2 will be there, and then more miscarriage. So single embryo transfer is always advisable when more paternal C2 homozygosity will be there. But let me tell you something about that. C1 is activation, hyperactivation. So let's say something, this is if you have a C1. So if the mother and father both are having a C1, then embryo should be always having a C1. And that is why there are a lot of people are saying that if there is a more C1 is there, these are having a more chance of the recurrent pregnancy loss or recurrent implantation failure, because there is a more activation, there is no silencing. Again, I want to say that if the C2 is there, then it is a silencing. But when you are having a all C2, that means the baby embryo will be always C2. That means it is a silence embryo. So they will not interact with the decidual natural killer cell, and they will not activating the decidual natural killer cell. So there will be no penetration, more chemical pregnancy, more pregnancy loss, or more implantation failure will be there in both conditions. So I want to say that when there is a more C1 and more C2 baby are there, this is also the patient those required more number of the embryo transfer, single embryo transfer, when there is the 3C1 or 3C2 when the husband and wife will be there. So let me tell you that favorable condition for normal implantation. Now I am saying that key is so important. So even you have a C1, but the maternal key is something silencing. So key is AA, then that's great. Even your embryo is terrorist, is your embryo is activating, but your maternal immune system, which is a key receptor, we are also finding out that in our condition that when maternal key is AA, and if the embryo is C1, then it's a favorable condition. Another favorable condition will be if the maternal embryo is C2, but key is activating, that means mother is quietly activating key system, BB, then again it is a good condition that you can transfer the C2 embryo. So these all things are opening the pathway that if you have a HLA C1 of both husband and wife is both are having C1, so all embryo will C1, then you need to see that if the maternal immune system is AA, that means inactivating, silencing. So this is a good combination. But if all mother and father is having a C2 and your embryo is C2 but mother is BB, so this is a good prognosis. I want to say that when you are trapped in a multiple implantation failure, multiple pregnancy loss, HLA Keel complex, not only HLA Keel complex is so important, which will guide you that what is the prognosis, selection of the embryo, and also way forward to reduce the loss, pregnancy loss, improve the per embryo transfer success rate is also important. So unfavorable condition, that means you are having a silencing embryo, but again the maternal key system. Here you require more about the egg donation. When C2 is combined with the AA, if you get the C1 egg, right, then there is a chance that the egg donation is required when both are silencing. And here when you are having all C1, and also again here the egg donation and sperm donations will be more important. Or you can change the embryo to transfer in the surrogate mother if there is a multiple miscarriage and multiple implantation. So this is again how to explain the prognosis to the patient way forward, that where egg donation will work, where sperm donation will work, and where surrogacy will work. This is again a very good condition that you can prevent. If you want only go for the surrogacy specifically in this condition, then might be possible that patient got a pregnancy without changing the gametes. So I want to say that now we understand that opening the HLA key system we will always important, and I'm doing something whenever there is all three PGT normal embryo transfers and patient arrived at my clinic, multiple pregnancy loss after 4 PGT single embryo transfers, again they do have a no implantations. I will be happy to do all these tests will be there. So combination, again this is the one paper which was published recently and they say combination. Look at this combination. I already say that if C1 is there, so if C1 is there, it is activation, and if it is associated with BB, then again there will be a definitely a pregnancy loss and no implantation. But if there is a C2 embryo is there, and if there is a AA, then again there is a problem. So here they are showing that if embryo is C1, and if there is, you can see something, the combination of BB, then higher chance of pregnancy loss and higher chance of implantation failure will be there. So here the condition that how we can find out the HLA of the embryo and prioritizing the embryo according to the key system, and we can increase the per embryo transfer success rate in recurrent implantation failure and recurrent pregnancy loss is there. Again, this is the most important carry home message, that HL is C2. If you are a C2 is very important. It is more immunogenic if they are coming from the third party. That means husband is also something a different party for a mother, And if you have doing a donor oocyte, then again, if the C2 will come, then these are having a high immunogenic, high rejection. And that's why when you are doing a 2 embryo transfer in a donor, and if the donor is having a more C2, so more C2 implant, or even your husband is having a more C2, more C2, so double embryo transfer, where you can change your strategy to single embryo transfers, then you will get less rejections. I want to say that single embryo transfer is again a way forward to increase the recurrent implantation failure, to reduce the recurrent implantation failure and the recurrent pregnancy loss. Now, let me tell you, this is the same thing that paternal C is often associated. If you have a paternal C2 is there, then there are high chance of associated pregnancy loss and the implantation failure is there. Now we can say interaction. So now your signature is fine. Your sharing is already covered. You saw that there is a paternal antibodies there. Immunotolerance is good. Your maternal, your embryo Kir complex is good. Now this embryo will enter into the systemic circulation. That means in the blood. In the blood, there is a different system which is called HLA class 2. And it is called as a DPDQDR. So this is a different system. It is called systemic interactions. I will call that. And how to find out? This is DPDQDR. So if there is this maternal immune system, which is called as a systemic immune system will be there. They have again, when embryo goes inside the blood, depending on their alleles, they will react. They increase platelet aggregation. If there is a paternal C07 is high, they increase some reaction in the blood if the embryo is having a certain combination of paternal and maternal alleles. I want to simplify that. So whenever the embryo will goes and taking the blood supply, there are so many alleles combination will like to reject the embryo and will land into the recurrent implantation failure or recurrent pregnancy loss is there. So this is what I want to say, that these are the different alleles which are going to in the blood, and then it will lead to a more miscarriage and more pregnancy loss, or we can say more implantation failure will be there. Where I need to say something. So we are doing individualized immunoglobulin therapy. I don't want to do something blanket. I say only 2% of the people required IVIG. I will not do IVIG until and even I don't know the HLA of the embryo, the Kir of the embryo, and then I can transfer, can advise that this patient is required IVIG or not. I will not do IVIG as a blanket therapy. And again, I will do only low molecular weight heparin if there is a paternal C07 is there. So there are a lot of things to explain you. This science is really amazing. And we treated around more than 100 patients. Now we are about to publish our individualized data of donor LIT, individualizing the IVIG in the recurrent implantation failure and recurrent pregnancy loss. And a lot of things that where GCSF, IVIG, lot of things are there which we can improve. This is our own 800 patients data is there. And where we say that how in the Indian scenario where the C1C1 is higher, frequency of the HLA typing will be said the C1C1 frequency is very higher. That is what we can say. And the potential high risk frequency where you will find out most miscarriage. So we are finding out the hierarchy. We'll give you idea that which the halotype will increase the chance of the miscarriage and implantation failure will be there. So this is our data segregation, that why we are showing something of the risk factor of the different alleles will be there. So what is my conclusion? No add-on before 2 or 3 euploid embryo transfer for implantation failure and RPL. All C1 and C2 are having lower prognosis in implantation and RPL. All C1 with BB Kir or all C2 with AA Kir having poor prognosis. Always choose natural or modified stimulated cycle. So I will like to say that the answer which was I'm giving, that if I'm using, I'm treating a patient of recurrent pregnancy loss and multiple implantation failure, then it is always better. Modified stimulated cycle will be better because it will give an immense good immuno profile compared to the HRT. But be aware of the endometriosis. Rest of the endometriosis you can go by modified stimulated with the letrozole and you can transfer the embryo. So my conclusion is abnormal signature of the embryo will increase the RIF and RPL, require research. Sharing will require donor LIT. I don't believe in husband LIT, and systemic rejections will be counted by individual by the immunotherapy. And in our unpublished data, 15 patients carrying C1C1 genotype having more chance of the surrogacy. C2C2 in a couple require egg or sperm donation. Single embryo transfer strategy is way forward to treat any immunological related implantation failure. That is what the message I want to. Thank you so much. And thank you for attending my lecture. Thank you.
Thank you, Dr. Jayesh. Is Dr. Praful Doshi here? Wants to conclude the topic? Okay, I'll just do that. Thank you so much, Dr. Jayesh. And I think a lot of comments in the chat box saying that it's a complex topic. There are still unanswered questions, but you explained them very nicely. There are a few questions in chat box. I will ask Dr. Jayesh and Dr. Ritu to cover it. Dr. Anjana Rathi wants to know the role of thymosin in recurrent implantation failure. Anybody can take Dr. Ritu or Dr. Jayesh.
Alpha, we haven't used, but it has just come in. I have not used for any patient. Although I wanted to say this, but still I have not used, and it is not recommended as a standard therapy anywhere. So did not touch upon it. It is now there in the market and it is available also. 9.
In alpha, basically it was used in the COVID time.
Yeah.
That if you see something about in the COVID time, they want to actually activate the immune system, right? So they give for that time. So they are saying that during implantation failure, most of the time the immune system is not activating and silencing, and they are giving so many injection to activate the immune system and more decidual natural killer cell that will be protecting the embryo, what they are saying. But I don't think so. What I want to say that don't act until 3 euploid embryo transfer. So I never take a case, whatever my this much number of the cases, we never act beyond 3 euploid. We will always transfer single embryo transfer because we now being a organization having last 1.5 years, we are transferring only single embryo transfers and our results are not down. If you transfer single embryo, you need to explain the patient that, but it should be genetically tested. Your demography should be like that, that there is indications where you can transfer genetically tested embryo transfer, single embryo transfer. But after that, I think so. If you want to do if you want to give any immunotherapy, then without opening the crosstalk, every immunotherapy is a waste of money. Means if you give IVIG and you are transplanting the embryo, which is called C1C1, and her key receptor is BB. That means if any husband and wife, they have a probability of 25, minimum 25%, they will produce C1C1, C2C2 like that. And if their match with their key is activating, so activating, matching with the activating. So the ultimate thing is that complex is not better. Whenever this complex will come like activation and deactivation both. Then systemic rejection is there, and then if there is a systemic rejection, then you can give all the systemic interaction therapy. Before that, if you give IVIG, I think so you are wasting the money because IVIG is not cost effective, is around 1.5 to 2 lakh rupees and I don't believe in all this Barglobe injections because they are having very low dose of the immunoglobulin. I want to give a high dose titrate. Then there is a immunosuppression, specifically the antibody suppressions. So what we are doing, our report will suggest that there is autoantibodies and there is a high chance that these alleles are there. So there will be a strong relation with the miscarriage and implantation failure. But instead of when I perfectly know that key is AA and my embryo is C1C1, and specifically when the patient is coming with the 3, 4, 5, 6. Yesterday I have 8 IVF failure from Tanzania. So what I can do? They all are transferred, every strategy which was they investigated, and the patient is not ready for any donor program. See, I want to say that those who are very much flexible for donor, for them, it is a tip of the iceberg. I don't think so. Those who are using donor very frequently, implantation failure is no implantation failure because you are changing the whole immunology, the key complex and polymorphic situation, everything you are changing, then I don't think so. Those who are frequently using egg donation and embryo donation after implantation failure, there is no point to investigate only and only with their own oocyte and own sperm. Yes. Then there is a point after certain implantation failure that what is the reason? Then we can go ahead with the KIR and HLA complex. all immunotherapy can be given only when you know the complex. Before knowing the complex, if you give IVIG, then 50% you will be failed because complex 50% will come abnormal. So ultimately, there will be no point of giving any immunotherapy which is launching in the market as a giving of the empirical.
Dr. Jayesh, are you are giving a donor? You said donor immunoglobulin programs. So
Donor LIT. That means
LIT, yeah. So
donor LIT. When your
so.
report shows that
Mm-hmm.
see, we have almost now we are having 50 patients where the genetic compatibility is more than 60% matching. Their alleles are 60% matching. And the history is
Okay.
very simple. They have in US 5 embryo, single embryo transfers. They don't have a pregnancy. That means they are 5 embryo transfers, 4 embryo transfers, genetically embryo transfer. There is no clinical pregnancy also, right? And when you go for that genetic compatibility in this type of the patients, if there is, you give only donor LIT. If patient is young, the patient will conceive spontaneously. We have a 5 patient after 5 implantation failure, 31 year in Melbourne, US, Melbourne, and they have a 5 single embryo transfers genetically non-tested in 31 years of the age. They arrived at my clinic, and then when we see around more than 6 alleles are matching, I counseled the patient. We gave low dose LIT of donor LIT, and then I said
So
that
I
you want
just
to wait for 6 months, go 6 months. They already done IVF in my IVF to ho gaya tha, IVF already done. But I said go 6 months and come after 6 months. Maybe you will get this initial pregnancy. They will get initial pregnancy. So what I want to say that see every implantation failure when you investigate, you will find out certain group of the patient those who are very treatable. So when you go depth inside, some people are treatable. Then again, when you go inside, then something signature is wrong. Then again, you treat it. Again, you give certain patients systemic rejection. But some group of the patient, there is no doubt about it that you require third party donation. The bad prognosis. But then you can on the after 4 implantation, 4 miscarriage, 6 miscarriage, 8 implantation failure. Doing HLA will give the prognosis that
okay.
don't wait on your own egg. You require donor egg, right? So that will unnecessary expenditure will going to reduce. Sometimes what happens that unnecessary embryo that we are throwing inside, which can be reduced by doing a donor LIT, because at 38 years, they hardly form two genetically normal embryo. And you waste the embryo, and then next time the patient is having a problem in the embryo formation. So you know that how infertility come in our clinic. It's all about the 11 different challenges that you are facing.
So I just have one question, Dr. Jayesh here. When you say donor, do you check the HLA compatibility with
Yes,
the donor as well?
we checked 10 donors we kept ready in my hospital. So I know about the all 10 donor HLA,
Okay.
right? Those who are doing, and then I will according to that, I will take that donor and then I will do LIT in the same patient. The 10 different options will be available because hardly it is 60 ml blood is required to from the partner, the one of miss from the man. So I think so we have a 10 to 15 donor inside my because we have a 200 staff in my hospital. So what we are doing, we 15 patients, 15 man we allocated. We are frequently checking them and we know that what is the HLA of that man. So by
Okay.
that, we can
Nice.
exactly by seeing that mother sharing and everything, and then we will use which HLA is required. See, I think so. Sarajan people, Dr. Vasanti is with me. She is the backbone behind me. That she's advising me that what exactly which couple which required this is the matching and this LIT will do that we will do together. So this is I'm always keeping on us, but we are having a full total 10 to 15 male those who are having a different HLA typing of the blood will be there.
Is there any ethical consideration you take into account?
Yes, we are taking a lot of consent. We made some different consent also because long term, we already explained that long term, any complication is we don't know. But till now, I think so. It is this treatment was done from 1974. It's not something LIT is a very recent. If you see the publications and everything, people are doing LIT before also IVF. That they are doing a donor LIT, means they are doing a husband LIT, and there are a lot of donor LITs also there. So, and again, we found that if you give any LIT, it will not last, effect will not last more than 9 months. So after 9 months, if the patient will come again, you need one more LIT. This is not the response that you are creating inside the body, which is going to be lasting forever. Why? Because it's only about your see, when the husband is there, he's keeping intercourse again and again, right? So that will be again, but this is something when you are having a this lymphocyte, which is from the donor, what we feel that after 9 months, the effect of the LIT is not there. So we recommended that after 9 months, we have to repeat if something, they will come for the second pregnancy. And if we again fail.
And
Yeah,
are you doing NK cell in
So we
routine
don't
checkup?
do NK cell. See, let me tell you what I say that understand the physiology. See, whenever the foreign material will go, so when the embryo will, sperm will go or embryo will go, there will be a peripheral blood natural killer cell elevation. And decidual natural killer cell elevation, it is basically good for the baby. So there is no point. The point is which decidual nature killer cell is activating and which nature killer cell is having a silencing. And for that, we need to find out that this is always done by the HLA kill complex, right? But I don't want to say something in each and every patient. You can go by the HLA kill complex.
HLA type.
I'm segregating. I'm giving the prognosis, and then I'm going to segregate the patients and just getting a one by one that which patient required sharing donor LIT, which patient required HLA type key complex of the embryo, which patient required systemic interaction, that is systemic therapy. So this is what we are doing. I think so we should stop doing the uterine nature.
Sir, one last question, sir. Good evening, sir.
Good evening. How are you?
Fine, sir. Sir, what do you think is the role of thymosin? So much it is being talked about it, and so much of lectures are there, sir.
Don't use thymosin. It is a useless product. That is what I can say. At present, it's a useless product. Is a marketing product. You might have a certain implantation in certain cases, but it is because of the variability of the HLA key complex. The major thing is HLA key complex and systemic interactions. I think so. Rest of the other thing you are doing is wrong.
Sir, if like we are doing donor, suppose in a couple with a donor oocyte and donor sperm, both of them. So what?
Any egg donation and embryo donation program, if there is a systemic rejection, is very powerful. See, when surrogacy is required, egg donation and surrogacy when required. I have a 2 patient, those egg donation, even egg donation, they require surrogacy. That I told her on a first day, you will have a multiple miscarriage, and they have a 8 transfer, 7 miscarriages, right? And on donor egg, right? Last 4 transfer which was done by me by single embryo. I never transferred. You know, Dr. Babar, you are here. So you know that what I am practicing, I am always transferring embryo, right?
Sir.
We are transferring only single embryo, and still if there is a miscarriage, so that is completely systemic rejection. And we need to find out which variety of the DPDQDR. And then the combination of that is having a very high systemic rejection. And you need to counsel the patient that you required. So lot of things are, we can counsel the patient. Unnecessary number of embryo transfer we can reduce, and we can divert the patients for a good psychology and good physical output.
Thank you, sir.
Thank you. So I think we're running, we are already above our time schedule. Any questions from the audience, or otherwise we'll conclude this webinar. No, thank you so much, Dr. Jayesh. And I think this the take-home messages from the overall webinar is it's very important what Dr. Ritu said. It's important to rule out the baseline causes of implantation failure. I think that's the priority. rule out, make sure your protocols are right, make sure your embryo transfer technique is right. And I think if you are confident with that, then only you move on to your higher technologies and advanced technologies. So get your basics right. And then if you're still struggling, the way ahead is immunology, genetics, that definitely things are advancing. We have our own data now. Hopefully, Dr. Jayesh has also presented it. So these are all promising data. So let's hope that the future is bright for patients who are frustrated with recurrent implantation failure. So
Dr.
thank you. Thank you.
I want to say only one thing, that if I say that single embryo transfer is necessary and or compulsion, right? Then I can say in the future, when we are treating more 35 and advanced maternal age, where forming the embryo is very difficult, I think so the message is very clear. When you are treating advanced maternal age and recurrent implantation failure, the single embryo will be a best strategy. That is what I believe, and that is what we are implementing. It's only your counseling should be very perfect, because people are always shouting when there is a first embryo transfer and there is no pregnancy, right? So you need to counsel that anyhow you can have a 1-1 transfer, you will get the pregnancy. But when you transfer double, then paternal antigen load is very higher. So once you have this much of implantation, or you are having a previous implantation and previous miscarriages by 2 embryo transfer, then never transfer the double embryo. Then always counsel the patient that you already gone through the 2 embryo transfer. Now I can go for the single. So single embryo transfer is one of the best strategy, rather than to do more all these all fancy things that will come later. Right? I can't do anything if somebody has not done single embryo transfers.
Okay, thank you.
Thank
You very much,
And
Dr. Ritu. You want to add something?
yes, we want to have this lecture, it was so clear, but still I think immunology is such a such difficult thing. You can only clarify. The way you did was
So
excellent.
masterclass, it's for it around 2 hours and 3 hours masterclass is required.
Yes, yes. I think you need to
Yes,
do a
yes.
master class of immunology.
I'm going to
Yes.
start this masterclass in the
Mhm.
different part of the country, because we are launching reproductive immunology and reproductive genetics and immunology, and where we can go in Delhi or anywhere, Bangalore and Mumbai, and where we want to understand the exact what is exactly, because I think so future beyond PGT. If you don't want to do egg donation after 3 PGT normal embryo transfer, the only answer is immunology, nothing else, where you can open the box, right?
Thank
Thank
thank you.
you.
Thank you,
Thank you.
Dr. P.
Thank
Thank
you.
you, everyone.
Thank you.
Sir,
Thank you very much, everybody, for joining, for patient
thank
listening.
you.
Thank you to all the
Thank you.
faculty. Thank you, all delegates. Thank you, IFS, for this wonderful platform where
Excuse me, ma'am.
Yes, who's that?
मैम मैं ऑडियंस से डॉक्टर बबलू त्यागी
Mhm.
मैम मैं एक डेंटिस्ट हूँ बट आई वांट टू डू परस्यू माय करियर इन लाइक clinical embryology. Is there any chance or scope that I can become a clinical embryologist?
So the current law needs MSc clinical embryology. So you have to do masters in clinical embryology to be able to be recognized as an embryologist as per the new
Okay.
IRT guidelines. Yeah.
Okay. After that, ma'am, what
I think
course
you
I
can
can do?
message me. I'll send you
Okay,
my
okay.
number. But the thing, this webinar,
Okay, ma'am.
let's kind of wind up this webinar. By all means, you're more than welcome to message me personally.
Okay, thank you, ma'am.
Okay. Okay. Thank you so much for everyone again. And thank you to everybody who kind of heard, asked questions, and the way